Um, okay, so yeah, let's get started. Thanks everyone for joining. It's been a couple of months since we had a tag, but I think we're happy to be meeting with you in the new year. And Matt, if you could go to the next slide, that'd be great. So this is our agenda for today. We're going to have this quick agenda review, then we'll share a couple of program updates. Then we're going to go over the 2024 provider organizations lists and talk a little bit about next steps for provider organizations over the coming months. And then we're going to have a reasonableness meetings reflection to talk about the reasonableness process that happened for the first time this year after rulemaking was done this summer. That went from sort of August until yesterday, when those of you who had a reasonableness meeting should have received your reasonableness determination. So we're going to talk about that a bit, and then we'll just have a wrap up and talk about the next meeting. So next slide, please. Program updates. Okay. So first program update is just an update on the validation process for the cost growth target data that were submitted this year. So this is the cost growth data, our main annual data submission that was due in September 2024. We had a little bit of a rockier process this year with data validation, mainly because of the new medical pharmacy reporting process that I think folks, we're working out some of the kinks, and we're working on our guidance as well to improve that for next year. But we had a lot of resubmissions this year. At this point, we have most of the data at the payer level validated. We have one resubmission remaining and a couple of files that are requiring final clarifications, but we felt okay enough with the data to move forward with identifying provider organizations and starting to generate provider output, which we'll talk about quickly in a few slides from now. But yeah, so that's CGT1, cross-growth data validation process, and we can move to the next slide. This year, we also had the CGT4 frontline workforce data collection that happened for the first time. So that was due December 6th. Normally in future years, that's going to be due at the same time as the CGT1 data submission, but because rulemaking only ended in July this year, we pushed the due date back till December. And as of this month, we had received all of our required data submissions for the frontline workforce data submission. We got 25 submissions from different provider organizations this year. And out of those 25, we had 10 files with no need for resubmission or any clarification. And then we have 5 files currently that either need a resubmission or have some clarifications pending. That data submission is generally just fairly simple, just a couple of numbers on your operating costs, total compensation, and frontline workforce compensation. So there weren't, tons of different ways in which the data could be incorrect. But we did have a few files that had things like the total compensation costs, which should be part of the operating costs, being greater than the operating costs, or the frontline workforce costs being greater than, or in any case, not a subset of total compensation. We also had a couple issues with the cover page totals differing from the detailed subpage totals. In a few cases, that was actually a little bit on us because we had some kinks in our template, which we'll work out for next round. But overall, it was a fairly smooth process, and it's not nearly as involved a validation as the CGT1. So we're hoping to wrap that up in the next couple of weeks. Does anyone have any questions on any of the validation updates that we've shared so far? Not so much. Okay, next slide. So our final program update is just an update on the Oregon Health Policy Board Affordability Committee. That's the new committee that's being created by the Health Policy Board. You might have noticed, and I think we sent updates the last couple of months, that the CGT Advisory Committee has been sunset. So this affordability committee is going to take on some of the work that that advisory committee was doing in terms of looking at policies for reducing healthcare cost growth. But it is going to have a little bit more of a focus on a sort of broader range of potential policies, looking at affordability writ large, as opposed to just issues related to the cost growth target program. And the idea is also to have a somewhat different membership that's going to have more of an emphasis on purchasers of healthcare and advocates, with some industry participation. So that committee is sort of in the works. The Oregon Health Policy Board met on January 7th, and they discussed a couple of different potential models for the Affordability Committee in terms of the membership and structure. They also had a draft charter that they reviewed. In terms of next steps, the board is going to discuss potential seats for the Affordability Committee and the Industry Advisory Committee at their February meeting. So essentially the model that they decided to go with during the January 7th meeting was a larger committee that is mostly purchasers and advocates, but then also an industry advisory committee that will have a smaller membership and will be weighing in on more technical aspects of the issues and policies that they're considering. So we're going to move forward with that in February. OHA is going to begin recruitment for those groups also in February. And then just a final note, normally if the CGT Advisory Committee had continued, it might have taken on the task of reviewing the cost growth target benchmark value for 2026 to 2030. Since the advisory committee is no longer in existence, but that is something that needs to happen. We're going to form an ad hoc committee this summer to revisit that target and see if it needs to be adjusted. Currently, it's set at 3% instead of 3.4%, so it's set to go down starting with 2026 cost growth period. Yeah, so that committee will be sending out more information about it in future months, I'm sure. Does anyone have any questions on the affordability committee updates? Or Sarah, if you have anything to add, since you're more involved in that, feel free.
Hi, everybody. Just a quick clarification, Margaret. I think the current proposal for composition for the new committees of the policy board, the affordability committee will be the smaller group. I think right now the current proposal is that would be a 9-member group, and the industry advisory committee would be larger. This is a model that several other states have used, I think Massachusetts in particular. And so the industry advisory committee might be more of a 20 to 30 member body, and the affordability group would be the smaller. So just more to come on that. I think if folks are interested, the February board meeting would be a good place to listen, and then we'll share updates, of course, about where that's moving, as well as pushing out the recruitment announcements as soon as that goes live.
Great. Thanks for the clarification. Okay. If there's no questions, I think we can move on to the next section. 2024 provider organizations. Yeah, thank you. So since most of the CGT1 data has been validated, we were able to create our statewide file sort of late December, early January, and that allowed us to cross all of our submissions from payer to payer and roll up the number of member months by provider organization and determine which provider organizations had at least 60,000 member months overall in a given accountable line of business for both years. Or I think the rule is also 120,000 across lines of business as well. But in any case, we came up with our list of provider organizations that met the threshold for the number of members they were serving and number of member months that they had in 2024 data submissions. And it ended up as a list that is pretty similar to previous years, which is not overly surprising. We have 54 provider organizations this year that are going to be participating in the program. that included 2 new provider organizations that didn't have enough member months in previous measurement years to be participating in the program, but did this year. We also have 2 returning provider organizations, which are organizations that were participating in the program in previous data cycles, but then fell out last year because they didn't have enough member months, but are now back this year with adequate member months. And 2 provider organizations were also dropped relative to last year because their member months went down for 2023 and or 2022. So we ended up with the 54 provider organizations, 22 with enough commercial member months, 50 with enough Medicaid member months, and 12 with enough Medicare Advantage member months. Next slide, please. So this is just a list of what those provider organizations are. As I said before, it's very similar to previous years. We have a star next to the 2 returning organizations, and these are the provider organizations less FQHC and PEDS. But Physicians Medical Center and Broadway Medical Clinic are the returning organizations that were previously under the program, but dropped out last year and came back this year. Otherwise, this list is fairly stable from last year. Next slide, please. And this is a list of FQHCs and pediatric clinics. We did have 1 new FQHC, G Street Integrated Health, and 1 new pediatric clinic, Siskiyou Pediatric Clinic. And we're meeting with those entities hopefully the next week or 2 to give them an introduction to the program. Next slide, please. So in terms of next steps for provider organizations, we did send out the list of organizations to everyone in sort of a last email about 2 weeks ago now, just telling you that you were going to be participating in the program this year. We are planning in the next week or 2 to start sending out actual data summaries with your cost growth and all the details by service category, line of business, payer, et cetera. So you can look out for that email. The email will also include the opportunity or a request to schedule a data validation meeting. We're not going to require everyone to have a data validation meeting, but potentially those who are over the cost growth target with statistical confidence and a certain number of larger provider organizations will have a mandatory validation meeting, but we'll communicate that to you with that email in the next week or 2. And then we are hoping to get data validation at the provider organization level started from February, hopefully not going past April. And then reasonableness conversations for those who end up being over the target will happen on a sort of rolling basis. So after you finish the validation of your data, if you're over the target with statistical confidence, you'll receive eventually a reasonableness meeting notification, and then we'll start scheduling those conversations. And just a side note, this is not provider organization related, but for payers who are over the target and who have finished validation, we'll probably be contacting you within the next couple of weeks as well with a reasonableness meeting notification. Sarah.
Margaret? Yeah. Can you say a few things about the data summaries for this year and some of the updates that we're making?
Yeah, so we are actually expanding the data summaries a little bit this year because we want the provider organizations to have as much detail as they need to be confident in the data that they're receiving and to also be able to sort of understand where their cost growth might be coming from to the most granular level that they can. So we're going to send you basically the same data that we sent last year on some levels, but then we're adding a supplemental data output just sort of automatically, and that's going to include by payer. So we'll look at like your top your top payers. So any payer that represents at least like 15% of your membership, I believe is a threshold that we decided on. And so for each of those payers, we're going to give you a breakout of your cost growth by payer, and even down to the sort of service area, service category level. So your pay, say you had a higher cost growth with a particular payer and it was all in hospital inpatient, we might be able to look at that and see, oh, maybe there might have been like a high cost inpatient outlier there that we would maybe want to look into. That could be a possible reason for growth if you're over. And we were making those outputs available to folks upon request in previous years, but we just decided this year that everyone should be able to just get that data from the start so that they have the information and can look into it and maybe identify validation issues as well, even before we get to the reasonableness level. And we'll also have some information on your medical pharmacy cost growth as well, based on that data submission that we got from payers this year. So I believe those are the main updates. Sarah, you have another thing to add?
Yeah, I think, a lot of the payers and providers were contacted over the last couple of months where we had requests. Providers had a question for payers where we needed to kick that back, or a conversation or some data sharing needed to be facilitated between payers and providers. I think we're hoping that the expanded data summaries will not necessarily cut down on the need for those conversations or those requests, but it will make it a little easier to identify who and what, where those conversations need to happen. So just hopefully providing a little bit more insight, and so that providers will know which payers they might need to talk to or where those conversations should happen.
Does anyone have any questions on any of this? Looks like we adequately explained everything. Okay, so that is it for provider organization updates. Obviously, if you think of any questions later on, feel free to email us. And I think the next agenda item is our main sort of meatier one, and Sarah's gonna take that on, talking about the reasonableness meetings process from this year.
Yeah, quick, and we have a quick question in the chat. Yes,
I can share that link in the chat. Just a second.
thanks, Margaret. Okay, so let's move to talking about reasonableness. So I'm going to just set the stage a little bit and make sure we're all tracking where we are in the timeline. So this is the end of the 2021 to 2022 measurement period. So we had previously reported on this data last May. It was a really long time ago now. We had the public hearing, we did the rulemaking, we had reasonableness conversations. We're wrapping all of that up today. So when we think about who was over the target for this measurement period, there were 27 entities, payers, providers, and Kaiser, both payer and provider, who exceeded the cost growth target. So for those entities, if they exceeded the cost growth target with statistical confidence, after the rulemaking was finished this summer, OHA sent a notice to those entities that said, you need to participate in a reasonableness process. You can see the breakdown of the payers and providers by market on this slide. Next. So that notice said, you're over the target, here's what happens next, and here are the requirements for that reasonableness meeting. We did make some exceptions, and we did do some analysis on the OHA side and identify some reasons for cost growth up front where we knew that we didn't need to talk to every organization, so that we knew that there were some FQHCs and pediatric providers in particular where we could see what was going on in the data very clearly. So for example, during this time period, OHA raised the Medicaid behavioral health rates. There were behavioral health cost increases that pushed a number of organizations over the cost growth target in the Medicaid market. We knew that. That was an OHA cause and effect. We could see that in the data. And so for organizations where that was the primary cost driver, we said, we don't need to meet with you. We know what's going on here. Next steps. But there were 7 payers and 10 provider organizations that we did meet with to talk about the reasons for their cost growth. We provided some guidance. There was a new guidance document that came out last year, CGT 7, that talked about our approach to the reasonableness process, talked about the rulemaking and the reasons for acceptable cost growth. It identified a number of prompt questions that payers and providers might want to think about as they head into those conversations, ways to approach the data, trying to share a little bit about how OHA would be approaching that conversation. So we tried to push all of that out, but also with the expectation that this was the first time we were doing this process, and then we were going to be learning a lot as we went through and hopefully be able to tighten that up next year. Next. So, as I mentioned, OHA did some analysis and prep for those meetings. And just at a high level, what that included was reviewing the data for each entity. We looked at those data output summaries for the payers and providers, and we looked at what we were seeing. And this might look really similar to what we talk about with you all in validation meetings. What are the service categories with the highest growth? What are the markets with the highest growth? For providers, which payers are you seeing with that highest growth? We looked at additional data that we have at OHA. So for example, for all of the Medicaid CCOs, we were able to look at some of the CCO financial reporting as well as the risk adjusted rate of growth and look at that side by side with the cost growth data. We looked back at all of the conversations we had had with these payers and providers during the validation meetings. And some of you might remember that in the past, we've had a couple years of validation meetings, and sometimes those validation meetings do talk about reasons. This year, we tried to create more separation in those conversations where validation was just about the data and the reasonableness was just about the why. But that was not always a perfect hard line. And so we did have a lot of additional contextual information that had previously been shared that we were able to review and pull into that conversation. And then we also looked at trends overall. So we looked at what was in the annual report. We looked at some of our data analysis to say what was actually happening across the board for all large hospital systems or for all Medicare Advantage payers. How does this particular organization, payer or provider, how do they compare? Where do they fall in the range of their peers? Do they have different cost growth drivers than others did, than their peer category did? So looking at a lot of trends, and again, just trying to be prepared to come into those conversations with questions. Next slide. This chart is just a high-level summary of some of the reasons for cost growth that we heard from entities for 21 to 22. These are all acceptable reasons under administrative rule. So entities where this was the reason or a combination of these reasons caused that entity to exceed the cost growth target, they are not going to be held accountable. In future years, no performance improvement plans. This year does not count towards financial penalties. So a couple of these reasons and sort of which market this reason came up in. High cost outlier patients, we heard across the board. A number of the organizations that were over the cost growth target with statistical confidence had one or two or three very high cost patients or members. We also saw in this time period hospital discharge issues. We saw increased hospital inpatient costs because there were longer lengths of stay, because hospitals were unable to discharge folks to lower level or step down care facilities. This is a known issue in Oregon. There were no beds. The pandemic was exacerbating this, and we really saw that reflected in the cost data as well. Frontline workforce costs played into this during this time period, particularly Medicare Advantage and commercial organizations. We also saw a lot happening with non-claims payments. In this time period, again, particularly on the Medicaid side, there were a lot of increased incentive payments. So, for example, a lot of the coordinated care organizations pushed quality dollars out early to help stabilize providers. There were also other support payments that were made to providers to help stabilize their finances, sort of a lingering post-COVID effect. We also saw some utilization rebound, particularly for Medicare Advantage, as maybe older adults who had delayed care during the pandemic came back and sought that care, and so utilization spiked a bit. And then finally, I already mentioned the increased reimbursement rates on the Medicaid side, and we definitely saw that sort of loud and clear in the the data output for Medicaid. So this is just a snapshot. This is not about any individual organization, but this is more or less what we saw across the board for this time period. Next slide. So where are we? I said everything wrapped up today. So we sent all of the payer and provider organizations that exceeded the cost growth target in 2021 to 2022 their official determination of reasonableness yesterday. So all organizations should have received that letter. If you were waiting for a letter and did not get it, please let us know. If you think you should have had one and it didn't make it to you, let us know. And maybe our contact list is not as correct as it could be. Later today, I think we're aiming for 1 p.m. this afternoon. There is a public-facing summary report that is going to go live that will be posted on our website. We are also posting all of the individual letters that are sent to all of the organizations. So that is all going to be on our website, and we'll push that out to you all today. So this is going to wrap up our reasonableness cycle for 21 and 22. As Margaret said, as soon as we wrap this up, we're ready to start the reasonableness cycle for 22, 23. So payers, if you're done data validation, get ready to hear from us, and we're going to go into the next cycle of conversations. Next slide. So I think, Blaine, I'll come to your question in a second. So I'm going to tee this up. I think we wanted to spend a little bit of time with you as our tag, doing some debrief, some process improvement, some reflections. We want to hear from payers and providers who took part in the determining reasonableness process this year. Some of you might also be over the target for 22, 23. And so we want to think about, okay, how are you going to do things? What have you learned? What are the implications? How are you going to do things differently next year? But there might be other organizations that were not over the target in 21-2 who are over the target in 22-3, and it will be their first time having a reasonableness letter. And so they hopefully can learn from your experience. So we're going to ask a few of you to share, but really this is open to anyone, as well as questions from folks who might be curious about just how it went. So I think a couple of reflection questions to just throw out there. From the payer and provider side, we shared a little bit about how OHA prepared. How did you prepare? How did you look to think about what your reasons for cost growth were? What did you look at internally? What were the data or conversations that you had internally to prepare? How did you decide on how you're going to share that with us? We were really open and flexible in how we accepted this. So we had conversations. We had email back and forth with a number of organizations. Some organizations prepared memos. Some organizations wrote us a letter. Some organizations prepared a PowerPoint. Some sent us data templates. So how did you decide? How did you decide what made sense? Would you do it differently all over again? What would you recommend someone doing this for the first time would do? And then just how did the process go? Like I said, we tried to be flexible. We admit there was a lot that we were feeling out for the first time. What do we need to tighten up? What worked really well? What are some recommendations for improvement? So these are the questions that we want to open it up to the group. I think we've asked a couple of you if you'd be willing to comment to kick us off. So Kaiser, Advanced Health, and Summit, would any of you be comfortable jumping in here?
Well, I'm a really shy guy, so as people who know me laugh, I'll go ahead and jump in because this was a very fun process. Um, the first thing we did was we needed to realize this had to be a sleuthing kind of thing because if there's a driver, it almost implies that that is a reason. It almost implies that it's something unusual, and that's kind of that inquisitive type thing. So we started with was we looked at our data and we said, first off, we need to take a multi-year look at it, not just the 21 over 22, but what would we normally expect to be seeing, in this? Is there, we'll say, I'll call it the actuarial side of it. Is there this thing have high volatility and this just happens to be one of the up years versus a down year? So it was that kind of process one. The other thing we looked at was we said, well, what about the composition of people? So we certainly looked, even though we found it not to be a case or an issue, we said, well, let's look at two things. Let's look at the distribution of the business. When we talk a particular cohort of rate people, are they older or younger? I know that the claims are adjusted for demographics, but demographics as a risk adjuster really doesn't answer the question when you have something that's volatile. So we looked at both the demographic distribution as well as the risk scores to say, did something change in just the basic side of our people that really caused it to skew our data? So those are kind of the things we looked at to begin with. Then the idea was saying, well, let's get a little deeper now. Let's look at the areas that it was. We went in and we said, well, large claims is the first and obvious one because you can look at that. In our case, our information we had from our IBNR side of things, because we track what our reserves have to be for some of these large cost type of items. So we acknowledged that there were some unusual things going on. And what I will tell people is don't just ask somebody to download your inpatient data for large claims, because it was an interesting thing for us this year that what really drove large claims for us was not standard inpatient. It was actually a lot of really high cost RX people. It was just very, very high cost things that any one individual, normally you wouldn't see any of them, but we got a couple of them that were well over $1 million. And so we were able to look at those kind of things on the RX, the inpatient, to get the large claims. And that was one of the things we determined. That was, I would say, easy to do because us actuaries could almost do that all on by ourselves. The next step, though, is we reached out to our partners in the MedEcon portions of the company, as well as talking to our accounting people, because we had a couple of weird things going on that we said, well, it seems like we've got a problem with people being in our hospitals longer than normal. Why would that be? And it was really great to talk to the providers. We're lucky because we actually have already established relationships with a lot of these people. And we can say, just what are you seeing? And we talked to the MedEcon, the accountants, and what we found was we said, well, we had two things going on. We had high nursing costs. One was because, well, we contract with the nurses directly. So we did see that immediately. And we knew that there was what it was just costing for nursing staff was just increasing very, very rapidly. And that's really outside of our control because we can negotiate it, but there's only so much you can negotiate. And with the high inflation and things like that costs. So it was kind of a double type thing, a cascading thing on the nursing side, because we said, well, we've got to pay our nurses on staff more, but we still don't have enough nurses because there's a nursing shortage. And so then we said, well, but we still have the nurses. So where are we getting these? Well, we have to go to the agency cost. And one of the things that we found was the cost of agency nurses was just going through the roof. And that was basically, you want us, this is what you're going to have to contract. And so we were able to quantify exactly how much increased cost we had by looking at, from, once again, wonderful work from our accounting department to pull very detailed information to show, well, how much were we having to spend and how many agency nurses were we having to hire? And what would, once again, looking at a multi-year, what would be an expectation of a normal trend? And so then that also then led to our last thing, I would say, which was interesting because we went through and said, well, we knew that the people were in the hospital longer and the length of stays were going on, and they were going on longer for people that weren't, we'll say, high impact type of things. They weren't staying longer because they were sicker. They weren't staying longer because they had complications. We really looked at what was happening with these patients, the why, and we found that we just didn't have places we could move them to lower cost of care because there was I would say there were nursing beds, but you can't put a person in a bed if there's nobody to watch them. And so what was happening is the skilled nursing facilities were seeing a shortage of nurses themselves, and we found that they did not have the capacity for us to move people from that higher cost of care environment into a more appropriate cost of care environment. And so those were the kind of things that drove us, I would say, for the 22 over 21. And we looked at a lot of other things too. And there were things we looked at, said, like I said, I looked at risk score and I said that there's some things that were drivers but not reasons. We were very careful in our minds to kind of differentiate between the two things. And in a simplistic way, we said drivers are things that are happening, such as trend and cost and things that were just normal things that we felt that we should be trying to control. But at the same time, reasons were things were just, why the heck did that happen? Something that really wasn't in our control, wasn't something we were working on already. And I would say the last thing is that when we go into the next cycle, we fully intend that it won't be a case that last year's drivers may not have anything to do with any drivers we have in the future years. So every year you've got to take a fresh look at it and a fresh kind of inquisitive nature as to what is driving your business. And a lot for us as Kaiser, this is stuff we do all the time anyway. I mean, this is part of our mandate to try and outside of the cost growth target for us to try and control costs. And I think that there's other players that have exactly this kind of same process.
Thank you so much for that, Greg. Chris, as a payer, anything there resonate for you? Anything, any similarities, any differences in your approach?
Yeah. I think a lot of those same factors were at play for Advanced Health. I think, going into the determination process, we had a really good idea about what was driving cost growth. It's something that we're looking at throughout the year. We're comparing our actuals to budget, and we're identifying key areas where we're exceeding that budget. So we had a pretty good idea of what was happening to start with. And a big factor for us happened to be catastrophic outlier claims. So, we're Advanced Health. We're a small CCO on the coast, about 30,000 members pre-redetermination. And because the cost growth reporting process, we're not accounting for any estimate for reinsurance recoveries. Those catastrophic claims are reflected as expenses. So you don't see the type of smoothing in the cost growth data that you would see on your income statement, for example. And for us, 22 happened to be a really terrible year for catastrophic claims. And I think it's just a law of large numbers thing. When you're a small plan, some years you're going to have 0 catastrophic claims, and some years you're going to have 2 or 3. And that's going to create a lot of volatility in your cost growth. So, I think it's really critical that the cost growth team at OHA has set up, that penalty process to account for, a longer period, a longer look, so that, an individual year isn't, driving, an improvement plan or a penalty. I think it's important to see, what's happening over several years. And so we were able to share that with the determination team, and it was found to be reasonable. I think some smaller year-over-year changes were rate changes, and of course, as a plan, we know what rate changes happened in 2022. Of course, we have the behavioral health increases, but we also had primary care rate increases, which were necessary as the cost of care continues to increase for providers, and especially in rural Oregon, as the payer mix that providers are exposed to becomes increasingly adverse, as commercial becomes a smaller and smaller fraction of their revenue. The other big factor was the quality pool, and so this is another one that bounces around a lot year to year, depending on how providers and the CCO do with respect to quality incentive measures. Our practice is to pay out all of the quality pool to providers. And so if we have a year where, we earn 70% of the quality pool, and then the next year we earn all of it plus a large challenge pool, that's a big year over year expense increase. And so I'm happy to see that, that each of these things are considered, reasonable and acceptable causes for increased cost growth. But for each of these, it was a really simple data pull. We just shared justification for the primary care rate increases and those associated rates, and then we shared some details about those catastrophic claims, including paid amounts. I don't think I would change anything about the process. I feel the OHA team was great, very understanding, and it was less scary than we thought it might be going into it.
And I promise we didn't ask Chris to say that. Thanks, Chris. Deb, do you have a couple comments from the provider side of this?
There we go. I do. Thanks. Sorry, it took me a minute to get that unmute button done. So Deb Foster from Summit Health. We are a multi-specialty outpatient group. So we really are serving patients in a non-hospital setting. And so I think that I really kind of want to mirror kind of where Greg was at, just because I think we had to really look at the community and what was going on with the community as well during that time frame. We live in a bit of a bubble in Bend. We're in Central Oregon. We're separated by mountains. And I think that when you look at what was 21, 22, it was like, Bend was the #1 place in mid-sized city in America that people were moving to during COVID. And it was that way for 2 years. And we were #2 overall city that people were moving to. So we knew that we were going to have some barriers with just a high influx of new patients. But I think looking at our strategic plan, also the fact that we expanded, so quickly into lots of multi-specialties, trying to serve the community, and really looking at our strategic plan and where for us being outpatient specialty and primary care, we really look at our overall mission is really to reduce the cost of care for patients and really focus on providing services in an outpatient setting at an outpatient cost. So we're not tied to a hospital. We don't get to charge facility fees. And so for us, we're really trying to reduce that cost of care by pushing more patients to ASCs for surgeries that are lower complexity, that don't need to be done, even though we're not tied to that ASC. So we're really always trying to push into those areas. I think I guess just to recap that, looking at the community and what was going on with the community, looking at your own strategy and how, like for us in particular, we expanded so much during that time. And we had up to 3 specialties that no other group in the community was servicing. So I think, when you look at for example, our nephrologists, we're the only in Central Oregon, And so when you look at that, people having to travel an hour and a half or 2 hours or 2.5 hours over the mountains to get that service, there's going to be some costs in these really complex, highly complex and high cost patients. So we knew that was going to be kind of also our challenge. I am looking forward to some of the supplemental data. I'll just kind of go into that. I think the process went really well. You did not pay me as well, like Chris. I think the process went well. I think, of course, it was very scary because when you look at our mission and how we want to expand specialty services, and then you see this sudden cost increase, but we're trying to do an overall take care of patients better, keep their, do care gaps, close, manage chronic conditions to have better outcomes to lower the patient's cost of care. And then us to share in savings, that's really our mission. But then to see like this potential penalty of like, oh my gosh, but our costs went up beyond what was like a normalized benchmark, right? But we kept patients out of the hospital. And so we were like, we get really excited about that piece. So just trying to like wrap your head around what the strategic plan of the state is versus what our strategy is. But I am looking forward to that drill down, because I do think that we will, and we have seen, the high cost patients. We have the luxury of having Epic. I know not every organization has that, but I was able to really easily go in and get into Slicer Dicer and Epic and be able to see these, I could have printed the graphs for you. Instead, I gave you lots of numbers, but maybe that's something I might do in the future, is, kind of do more of a PowerPoint format and show the graphs for growth. I think that it's powerful when you see it like that. Thank you for understanding, all of my, data that I pulled there. But I also want to go back to one thing Greg said, which is, risk adjusted for demographics. I hope in the future that the program really does look at, patients, with the multiple chronic conditions, because the fact that, especially us, we have a lot of specialty services, and some of them were really like the majority servicing the area. And we have oncology, we have rheumatology. Those are very high cost drugs that we're charging for infusions in an outpatient setting. So that really, like, I think, I'm looking forward to the data. I just hope that we expand the risk adjustment beyond just demographics. I'm hoping that we really look at the complexity of patients that we're dealing with, because when we look at all of our other value-based plans, that really also plays into benchmarking. And we are applauded by our commercial, our MA plans, and we're in an advanced ACO, so for standard Medicare, and we really are performing well in the fact that we are, containing cost by doing more frequent touches with patients with these high complexity diseases. So, any questions for me?
Thanks so much, Deb. I do want to acknowledge to the point about the demographic risk adjustment or additional risk adjustment. The OHA team did have a number of conversations with payers and providers as part of reasonableness about as it relates to the high cost patients and to some of the specialty services. Oncology drugs came up in a variety of conversations, and that was something that we took into account. I think the way I've been thinking about this, especially when I talk to other states that might have a different model for their cost growth program, we don't do the adjustment on the front end. We do want to look at the actual costs as much as possible, but we are allowing for that and digging into that on the back end during the reasonableness process. So I think we'll continue to have those conversations. We know that there's a lot happening with prescription drugs. We'll likely continue to see that as a major cost driver and see how that plays out, especially for patients with multiple conditions, multiple complex chronic conditions. And that is more something we want to handle on the back end rather than through risk adjustment. But totally hear you both that is a cost driver. Okay, I'm doing a quick time check. I know we're running out of time. I know there's two questions in the chat that I want to make sure we hit, and then open it up to see if anyone else has comments, questions, reflections. So Blaine, going back to your question, I want to make sure I understand what you're asking about the process for sending everyone a letter. I think, are you saying it would be helpful for entities that do not need to participate in the reasonableness process to get a letter from OHA saying you do not need to participate in the reasonableness process for this year?
Yes.
Okay. I think that seems like a reasonable ask. Does anyone else have any opinions about that one way or the other?
Yeah, given that I won't be here after April, I think it'd be helpful for my whoever takes over for me to have that as a good piece of documentation.
Yeah. Okay. I think that's a reasonable ask. Okay. I see some seconding in the chat. Okay. We will incorporate that. So revised plan, every payer and provider will get a letter from us after validation, either saying you've met the cost growth target, you're indeterminate for the cost growth target, you do not need a reasonableness meeting, end of the line for this year, or you're over the cost growth target, reasonableness meeting is needed, here are the next steps. Okay, cool. I like that.
Thanks.
All right, and then Jeanette, question about the timeline. Yeah, so I think Margaret answered. We're hoping to start the payer conversations. I mean, if we really are organized, we might start contacting folks as early as next week, maybe early February. We really wanted to wait until the report came out today and all the determination letters for 21, 22 were out the door so that we weren't crossing the streams of the measurement periods. It was already really confusing, and we didn't want to make that worse by talking about 2 measurement periods at the same time. But now that we've fully wrapped 21-2, we're ready to start 22-3 and payers, especially if you're done validation. I think you'll be hearing from us shortly. I do want to comment on the timeline. This was a long process. We have been talking to some of you about reasonableness for 5-6 months. We started this in July, and we only are wrapping it up now at end of January. There was a lot of back and forth. Some of that was just scheduling. It took time to get the right folks in the room. Sometimes we needed to talk to a payer and a provider together, and that was additional scheduling coordination, particularly those folks that are integrated systems where we needed to talk to the plan side and the provider side together, but also just separate payers and providers. Sometimes we needed to coordinate with. That scheduling took a long time. We also had a lot of back and forth, and entities would say, hey, we need to go pull data. We'll get back to you in 30 days. So then they would pull data. We would look at it. We'd have more questions. And they'd say, well, we have to go pull more data. We'll get back to you in 30 days. And so this timeline can stretch. So I think just like when we talk about the data submission and validation process, we want to get a little tighter and a little faster with it every year. I have similar hopes and dreams for the reasonableness that we'll all get a little bit better at this, and we'll know more what to look at. We'll know how to have these conversations, and we can shorten those timelines. We did have some questions from the public, questions during rulemaking about, will all the determinations of reasonableness be done by the time you publish the annual report at the end of May 2025? I don't know that we can promise that. If we're done, then great, that'll all be packaged together, but it might not. Just like this year, those might be separate reports just because it takes longer. So I think that's kind of a giant TBD on the timeline, but we do hope to start with payers very soon. And provider organizations, as soon as you're through validation, we hope to start the reasonableness conversations. It'll be more on a rolling basis this year. Okay, I think time for maybe one more question or comment before Margaret wraps us up. Anything else on reasonableness? Any process improvement suggestions for us?
Sorry, Sarah, this is Jeanette Sims again from Pacific Source. Just confirming that those reasonableness, the scheduling will go through the normal contacts that you're typically, and then we'll sort of engage the other folks from Pacific Source. Okay,
Yeah. I think we have a primary contact, and sort of the full contact list for each organization that we've been using for validation. That's who we used for the reasonableness as well. I think one process change that we might check in on this year is asking everyone who and where should the determination be sent to, just to make sure that we have the official. I think we have sort of the working points of contact, which are many of you for your organizations, but in terms of leadership, like who should the letter be addressed to? We might want to be doing that as a process check with all of you to make sure that our contact lists are correct.
sounds good.
All right, Margaret, wrap us up.
Okay. Annette, could we go a couple slides down? Yeah, so our next meeting, oops, you can go back one. So yeah, our next meeting is going to be on February 26th, about a month from now. Now we can go to the next slide. And we will be having meetings the next couple of months. We're not going to cancel them for February and March, at least in all likelihood, because we're going to be taking a look at any changes we need to make for the upcoming data submission. So payers, thank you for finishing your 2024 data submissions and validation. We're going to start thinking about the 2025 submissions the next couple of months and what we need to change in the guidance this year. I think we're hoping not to have huge changes in the guidance this year, since we had some larger changes last year. But that said, we've been sort of tracking issues that came up over the course of the last couple of months and, thinking through modifications we want to make to the guidance just to make it a bit clearer and hopefully better for everyone. And we've been doing sort of the same thing for the CGT4 workforce data as well. So our plan for the next meeting is to discuss possible updates to the data submissions for both CGT1 and CGT4. And then we might potentially touch base on some reasonableness guidance updates again. I think that's sort of TBD. But that is the next meeting, March. Then we'll actually hopefully have draft updated guidance to review. And then sort of TBD, I guess, after March, exactly what the conversations will be around. But we'll post these slides from this meeting online. Our TAG website is a little bit outdated, but I'm hoping to update that the next couple of days. And I'll send out an email to everyone with the slides from this meeting. And probably a link to that reasonableness report, just for ease of access. But yeah, that's what we got coming up. Look out for those notifications. I don't know if anyone has any last questions before we sign off. Seems like no. So thanks everyone for joining, and we'll see you at the next one.